So I like to record these for YouTube because then you've got a playlist to study from. So the ACE inhibitor will always end in pril. So there are lots and lots of different ACE inhibitors. In fact, I think if you pull up your blueprint, I think that, so enalapril is not the only one that you're going to need to know. Yeah, captopril is the other one. So it's enalapril and captopril. But you know what? You see one, you see them all. Okay, the ACE inhibitors have all sorts of things that are so in common with the next ACE inhibitor, right? And so you're learning these because they are ACE inhibitors. Now, there are all sorts of things about ACE inhibitors. ACE inhibitors, a lot of times providers will use like diuretics first for blood pressure. But if they're going to use an actual antihypertensive that's just focused on the antihypertensive part, often the first line antihypertensive after those diuretics are the ACE inhibitors. Okay, so we're going to talk about these, all right? And so this is the renin-angiotensin system. And you said, hey, the last one was a black picture of the renin-angiotensin system. This one's a little different. Well, they're both saying the same thing, okay? So the body does homeostasis pretty well, right? And the renin-angiotensin system is part of, or the RAAS, it is part of our ability to, it's part of our ability to compensate, right? And it's part of our homeostasis. So in this renin-angiotensin system, we have the body responds to this drop in blood pressure, okay, and drop in fluid volume. And what happens when we have this drop in fluid volume, drop in blood pressure, is our body, our liver goes, all right, let's send out some angiotensinogen, okay? Our kidney says, I notice a drop in blood pressure. I notice a drop in fluid volume. I'm going to release renin. And so that's actually what this is right here. I'm going to pull this up a little bit so you can see it. Nope, I guess not. So right here, that's actually what this is renin. There's a really clear picture of the renin angiotensin aldosterone system in the in ATI. So you can always pull that up. But this is released from the kidney. That renin causes a transition from angiotensinogen to angiotensin 1. And then the lungs actually notice it too. So they release something called this ACE. So the lungs release this angiotensin converting enzyme, okay? And that converts this from angiotensin 1 to angiotensin 2. But what happens with the ACE inhibitors is that it blocks this part of the pathway right here, where that ACE angiotensin converting enzyme is working. It blocks that ACE enzyme, okay? It blocks that. And so angiotensin 1 does not get converted to angiotensin 2. What results is then, because that does not happen, then the blood vessels can go big again, meaning they can go back to their vasodilated state. They're not vasoconstricted, which means the pressure goes down, okay? So this one over here, pressure was up because this RAS system was working, right? We've gone in, we've blocked this ACE, the RAS system is no longer working, right? So we're blocking that out. No more of that vasoconstriction. And we're letting it all relax and get bigger. And the blood pressure part of it can go down, okay? If you don't believe me, go and spray a hose with your thumb over the end. That's kind of like this right here. Spraying your hose with a thumb over the end creates high pressure. Removing your thumb out of the way of that hose creates a little bit lesser pressure, right? So that brings down the blood pressure right away. But it also acts on the adrenal gland because it has blocked this ACE right here, the body is also not going to release aldosterone, okay? So you will get a little bit of diuresis, okay? Little bit. Most of the action of this med is going to be right up here in allowing the vessels to be vasodilated. But down here, you're also going to block that release of aldosterone, which is going to mean they're going to pee a little, right? Okay. So what does that all mean when it comes to the medications? I'm just going to actually go backward and get rid of this for a second, okay? I'm going to pause that. So, sorry, ACE inhibitors can be used in the relief of hypertension, in the relief of hypertension with heart failure, so that we're not getting so much systemic vascular resistance on that heart. That's also something that ATI has remediation for, if you didn't get that when you were in patho. Diabetic nephropathy, sometimes it can be used with, but not very often. But it is often used for the hypertension in diabetes, okay? And I'm going to keep it as simple as that, okay? Again, this one, you can have the side effects of severe hypotension. Severe hypotension, why? Well, because you're giving it for hypertension and you're trying to bring down the blood pressure. It might get overdone, okay? A person can get a dry, non-productive cough due to a rise in bradykinin. And it has to do with the fact that we are blocking that ACE production from the lungs, okay? If somebody has a cough from this, if somebody has a cough from this, if it's problematic, so if it's disruptive to the client, they should be switched to an ARB or medications that end in sartan. ARBs are very similar to ACEs, but they have a less likelihood of causing that cough. Now, it doesn't mean they have zero likelihood, but they do have less of a likelihood. Okay, so I'm going to set that right here, and that's how those two relate to one another. Okay, now the person should change positions slowly. Why? Because we could cause severe hypotension. And so changing position slowly is really important, because if they change positions quickly, what they can do is they can, because we've caused that increasing of the lumen of the blood vessel, what we've done is we've created a pool kind of throughout the body, right? And when that person stands up, all that water goes to the pools down via gravity, right? So it goes to the lowest pools. And the brain is not the lowest pool. So if they're severely hypotensive and they stand up real quickly and their fluid all goes down to the bottom pools, they're not perfusing their brain, they could fall and hit their head, right? So Another thing that's really common with this medication, and I'm going to actually, I think I'd put this completely in orange here. Angioedema is a huge side effect, and I'm probably going to leave it really nice and big here. Angioedema, I want to bring back a picture of angioedema for you. Because I think it's really important for you to see it. Angioedema, and I want to bring it in an adult. Here is a very common one. I'm going to copy the image and bring it over. And then I'm going to bring over another one. Okay, so these are both examples of angioedema, okay? Angioedema just means localized swelling, okay? Angioedema can be very, very dangerous. If people are experiencing this localized swelling from this medication, I do recommend the ER. So here we go. Here's the first gentleman, and this is his angioedema that he's experienced, and his is in his lips. Now that's really, really dangerous, right? Because the lips are kind of close to the rest of the airway. The tongue is very, very dangerous because it's in the airway, right? It could, at any point, that angioedema could spread a little bit and cause problems with the airway. I'm not kidding. So you want to be very careful when people have angioedema. Now, if somebody gets an angioedema from an ACE inhibitor, they will never take another ACE inhibitor again. So if you see a provider order an ACE inhibitor for somebody who has a history of angioedema, you need to hold that medication, contact that provider, and bring it up with them. You know, I noticed that they've got a history of angioedema. I'm not sure what it's from, or maybe you know it was from another ACE inhibitor, and tell them, you know, I'm just concerned, and maybe they'll order something else. Sometimes they'll order an ARB, but sometimes they'll go with something different altogether. ARBs can cause this, okay, but not as likely. So these right here are potentially very dangerous things, which would cause the person never, ever, 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 ever to be on it again. So those are really the most important things about ACE inhibitors that I want you to take away. So that's really what I want you to walk away with ACE inhibitors, okay? And for this part right here, I'm going to move this right here, and I'm just going to add another one. Works on the RAS system, okay, by blocking the ACE, so the angiotensin converting enzyme that came out of the lungs, it blocks that. And by doing that, and causes basically vasodilation. I'm going to say more of a vasodilation state. And a little bit of diuresis. Okay? So that's really what I want you to walk away from with this. Okay?